Amla cream, that's a topical agent. And then we also use LET. LET is your lidocaine, epinephrine, and tetracaine, and that's a combination of your anesthetic topical agent. And then, of course, with injectables, we're going to talk more about those, but the ones that are really commonly used would be your 1% lidocaine. All right, so again, the indications of anesthetics is really to provide analgesia during surgical intervention, so that, whenever it is that you're providing, you're caring for your patient, and you do have this patient nice and comfortable while you're performing the skills and procedures. So another indication would be to reduce pain during your treatment of lacerations, incision, and drainage. And be aware that your anesthetics can be used alone or in combination. And so we'll talk more about it in a minute. All right, so here are some of your examples of anesthetic solutions. So lidocaine, xylocaine, that is the most commonly used. It does have a rapid onset. The strength that we have in your practice setting would be 1%. That is the most popular strength that we use. But also just be aware that you also have a 0.5% and the 2%. So the maximum dose for lidocaine is 5 milligram per kilogram. So that would be 30 cc's would be the absolute max dose. And that is a lot of lidocaine. So if you really think about it, you want to start with at least 5 cc's of lidocaine. You can go up to 10 cc's if the patient is not comfortable. But just being aware of the max dose is important, because you also want to consider the notion of lidocaine toxicity. And so patients with lidocaine toxicity typically would start, with neuro symptoms. So they would have neuro symptoms, the numbness, the tingling related to lidocaine toxicity, and eventually that would present as a cardiac symptom. So the patient would have tachycardia and also some hypotension, so low blood pressure. So you really want to keep an eye on these patients. So I talk about lidocaine toxicity because that's important for you to know. I also would like to talk a little bit about some patients that have lidocaine allergies. So with those kind of patients, you definitely want to make sure that you're not using lidocaine on them. Ice is a good place to start. So you can use ice on these patients. You also can think about using Benadryl. So that would be Benadryl IM. And it is injected exactly the same way that we inject lidocaine. Please don't use over-the-counter Benadryl. That's not the preparation. This has to be, received from the pharmacist and intentionally used for anesthetics. And so it does provide the same anesthetic effect as your plain lidocaine. And so we'll talk a little bit about your lidocaine with epinephrine. Really think about the fact that the epinephrine does provide vasoconstriction. So this is a combination of your lidocaine with epinephrine. So again, the patient would have decreased bleeding. It does have a prolonged duration. So, your plain lidocaine, the onset will be 1 to 5 minutes. It does last up to 30 minutes. Lidocaine with epi does last up to an hour to 2 hours. So it does prolong the duration of the lidocaine. So I'll give you an example. The other day, I had a patient that had come in with an abscess, and this patient was on aspirin. So I did start this patient on, I started, with plain lidocaine, really just, trying to perform that incision and drainage. And the patient was bleeding quite profusely. So I did combine lidocaine with lidocaine with epi. So I did, after injecting the lidocaine, I did use lidocaine with epi. So that did decrease the bleeding for sure, and it helped prolong the duration. So it gave me more time to complete my procedure that I was performing. So lidocaine with epi, the strength here is 0.5% and 1%. The absolute max dose is 7 mg per kg, so 7 milligram per kilogram, and you do not want to exceed 56 cc's. That's a lot of solution. But again, being mindful of your maximum dose is important. And so with that, we're going to go ahead and talk about Marcaine, which is bupivacaine. That does have a slower onset. It does have a longer duration. The strength is 0.25%, and the absolute max dose is 3 milligram per kilogram. So again, your job as a practitioner is to make sure you calculate this dose. You know exactly the weight of the patient, and you do not want to exceed the maximum dose for sure. All right, let's talk a little bit about the techniques that we use. So you definitely want to gather your supplies, use the correct technique, and the correct technique is really going within the wound margins. You don't want to go inside the wound itself. You're making a wheel under the skin as you're going, and I will show you how to the two techniques that we use. I'm going to show that to you. So that would be the field block and the fanning technique, and so that way you're able to make sure that you inject all the wound margins and keep this patient comfortable while you're performing your suturing. All right, and then of course you want to anesthetize the wound with whatever solution you choose, so lidocaine with epi or without epi. And then, of course, you also want to check the patient's allergy history. So we kind of talked about that earlier. And then no epinephrine for digital block. So again, that is something for you to keep in mind. So what I tell my students, you do not want to use epinephrine for anything that dangles. So that would be the nose, the ears, the fingers, the toes, the penis, and the scrotum. You do not want to use epinephrine at all. All right, so moving on to your informed consent, you definitely want to consider obtaining an informed consent from your patient before performing any procedure, and I'll tell you the reason why. So I did have a patient the other day that had come in and she had asthma exacerbation. And so the patient, I did order Selumetrol, so that would be your typical steroid shot. And the MA that I was working with was a float MA that day. And so she did give this injection on the deltoid. And if you think about it, you do not want to use steroids on the deltoid just because, again, that's just a small surface area. And so this patient had symptoms of numbness and tingling, and she had come in 2 weeks afterwards, and she was threatening to sue the organization where I worked. And so what saved the day was informed consent because, again, we were able to get risk management involved, and the patient's informed consent was actually just shown to her. And, informed consent, the verbiage actually states that, death could occur as a result of whatever procedure we're performing. So informed consent is your friend as a provider because you never really know the outcome of the procedure that you're going to perform. And then again, I kind of talked about this already. So again, caution with lidocaine with epinephrine on anything that dangles. So because of vasoconstrictive properties of the epinephrine. So in the eyes, the ears, the nose, the fingers, the toes, the penis, and the scrotum, you do not want to use lidocaine with epi. And then, of course, you want to check for allergies. So it's your job to check the patient's allergies, check for the patient's allergies, and then think about the timing. So how long is this procedure going to last? How long would I spend performing my suturing? If it's going to take me about 20, 30 minutes, then you want to use the anesthetic solution that would last that long. But if it's going to take longer, like your bupivacaine would be a good solution to use because it lasts up to 6 hours, between 3 and 6 hours. All right, so let's go ahead and talk about the types of wound closures. So we have sutures, which we're going to talk about today, Steri-Strips and staples. And so sutures are most commonly used. We also use Steri-Strips for really linear, superficial lacerations. And then, of course, we use staples, again, to approximate wound edges. All right, I really like this slide here because it tells you exactly what type of wounds to close and some wounds that you do not want to close. So primary first intention, wound closure type, that would be your first intention. So the closure would be that you as a practitioner, you're actively trying to seal this wound. And that would be the case of, a patient that comes in with a laceration, and your job is to assess that laceration and decide if you're going to close it or not. And so once you make a decision that you're going to close it, then you want to use a simple suturing technique. You can decide to do a flap closure. Hopefully, that is what we do in primary care, urgent care settings. And really, primary first intention wound closure type is also used at the end of a surgical procedure. So with your secondary wound closure type, this type of wounds are left to close spontaneously. There's really no active intent to seal the wound. So if you think about wounds like your abscesses, if you think about wounds like your dog bites that are highly contaminated, you do not want to close them. You just want to treat them with some type of antibiotic and then just let the wound close spontaneously by reepithelialization, granulation tissue, forming in that wound and contraction of the wound occurring. And then for the tertiary wound, you definitely want to think about this as more mature wounds. And typically the wound care specialist should be involved in this wound closure. So typically what happens is that the patient would undergo some type of debridement. The patient may need to be treated with some type of systemic or topical antibiotics. And then eventually the decision to close that wound will be made. And of course, like I said earlier, the specialist should be caring for this type of wounds. All right, so I want to introduce this algorithm to you. I did obtain this algorithm from the American Family Physician website, and it does help you to know what type of wounds to close and the ones that you do not want to close in the urgent care setting. So again, a bleeding wound is a good one to close. If it is a bleeding wound, then the next question is, how do you achieve hemostasis? So if you think about it, a bleeding wound could be contaminated with debris or dirt, or it could be infected or is a bite wound. So definitely you want to start with irrigation. So typically I do start with some sterile water. I do use some normal saline just to irrigate the wound. You could use up to a liter of normal saline just to irrigate, make sure that wound is clean before suturing the wound. And then, of course, debridement and removal of foreign body is important, especially if a patient comes in and they have a history of glass laceration or any type of foreign body laceration. Your job is to make sure that you remove that foreign body. With glass laceration, you can get an X-ray because glass is opaque on the X-ray. So that would be a good place for you to, start and make sure that, you obtain that and document that you obtained some type of imaging before closing that laceration. And then with the deep tissue injuries, of course, you want to start with, assessing that wound, and you want to refer out a patient that comes in with any type of deep injury of the hands, the eyelids, the nose, the lacrimal duct, the nerve, any type of nerve injury or open fracture. So again, think of the fact that there could be a need to repair that muscle or tendon before, repairing the peripheral tissue. And that's why you refer the patient out to a general surgeon. And so once you've assessed the patient, there's no vascular involvement. So you notice that there's no, squatting of blood or any type of, nerve injury. The patient doesn't have any numbness or tingling. Or if, think about the fact that the patient could have some type of tendon involvement. So you want to make sure that you're pushing, having this patient push against resistance. If I'm unable to do that, then you want to suspect that this could be a deep tissue, tendon injury. And so you want to refer them out. So once you've assessed the patient and this is your patient, then you can go ahead and repair the skin with any other techniques that we'll talk about today. So for the purposes of this class, we will focus on the simple interrupted and your simple running sutures. All right, so laceration repair, that's your CPT code there. Remember, the CPT code is your procedure code. So you want to use that for sure to, take a look and document what you did for the procedure. So if you're as a practitioner in an urgent care setting, you want to document both the ICD code, which is a diagnostic code, and the CPT code, which is a procedure code. So the indication for a laceration repair would be really to achieve hemostasis and optimal cosmetic outcome while reducing infection. So that is really your job as a nurse practitioner or a physician assistant. So the rationale or contraindication of laceration repair is, again, to reduce infection and treat the wound appropriately, because that's our job, right? And so these are some contraindications you want to look out for. So if a patient comes in with any type of wound or laceration with nerve involvement, tendon involvement, major vessel, you do not want to close these wounds. They need to be sent out. If a patient comes in with wounds or lacerations of the eye, the eyelids, any type of bite wounds, severely contaminated wounds, you definitely want to make sure that they're debrided and are irrigated. And so this is not your patient. They should be sent out. Any type of abdominal cavity wound or wounds older than 12 hours, they're no longer your patients. So any wound that is older than 12 hours, you do not want to close it because you're going to risk infection. All right, let's discuss the suture material. So this would be your needle that we use for performing your sutures. So again, the criteria for a good suture material, the needle would be a good tensile strength. So you want to know for sure the gauge size of your needle. So in this case, with this picture right in front of us, the gauge size is a 2.0. And so again, we're going to talk more about it, but I just want for you to know that if you on the floor as nurses or as physician assistants, if you have, been in clinical setting, you know that an 18 gauge needle is thicker than a 27 gauge needle. It does apply the same way with your suture needles. So a 2.0 is a bigger gauge size than your 5.0. So a good tensile strength is important for you to know. Good knot security, and we're going to talk about that some more. Workability in handling, low tissue reactivity, and ability to resist bacterial infection. All right, like I talked about earlier, suture needles right here, 5.0 is small and 2.0 is big. So you want to use a 5.0 on the face when you're really thinking about cosmetic outcomes, and a 2.0 on the lower extremity, again, if you're really not thinking about cosmesis. But the typical sizes that you use for the suture needles will be a 3.0 or a 4.0. And then, of course, I want to also introduce the concept of a needle holder and the tissue forceps. So the needle holder is what you use really to drive your needle, and that helps you to take bites when you're suturing. And then, of course, the tissue forceps is really to grasp that skin and to really help you when you're suturing. All right, here are some types of suture materials. So we have the absorbable type, and then, of course, we have the non-absorbable type. And so the absorbable type of sutures that we use would be your surgical gut. So surgical gut, an example of that will be the chromic gut, and the collagen and synthetic absorbable. So synthetic absorbable, we typically start with your Vicryl or Monocryl, and these will be the two most commonly used in your urgent care setting for deep dermal wounds. And then your non-absorbable sutures, the ones that are pretty common would be the nylon and the polypropylene, which is Prolene, polyester fiber and silk, also, some options for you. The stainless steel and the barb sutures are used in your OR in the operating room, and we typically do not use those in the urgent care settings. All right. I really like this slide as well, and I'd like for you to kind of pay attention and see the reason why I like it. So this really tells you about time that it takes for your suture material to lose 50% of its strength. So I talked about the chromic gut, and that's an absorbable suture. It takes about 10 to 14 days to lose 50% of its strength. The Vicryl takes about 2 to 3 weeks. The Monocryl takes about 7 to 10 days. And then drop down to your non-absorbable. The nylon takes more than 10 years to lose 50% of its strength, and the Prolene is indefinite. So if you think about it, the patient definitely needs to come back to get the sutures out when you use your non-absorbable sutures. And so again, you can see the typical uses for all the types of suture material we talked about. And most of them, monofilament configuration is only the Vicryl that is braided, and that's why it's used for your deep dermal